Hi, my name is Trenton Buchanan, and I'm a research assistant in Michigan Medicine and an MPH student at the University of Michigan School of Public Health. In this presentation, we will be discussing antibiotic stewardship in the context of antibiotic prescribing for urinary tract infections. The objectives of this training will be threefold. 1. To recognize the importance of stewardship in antibiotic prescribing. 2. To learn implementation strategies for stewardship in antibiotic prescribing for UTIs. And 3. To identify how you and your facility can improve their antibiotic prescribing habits for UTIs. To start, let's define antibiotic stewardship. The Centers for Disease Control and Prevention define antibiotic stewardship as the effort to measure and improve how antibiotics are prescribed by clinicians and used by patients. Antibiotic stewardship is a massive topic upon which hours of trainings can be performed. However, today we are going to focus specifically on the underlying portion, how we can improve how antibiotics are prescribed. But first, let's dive into why the topic of antibiotic stewardship, including proper prescription of antibiotics, is so important. Antibiotic use leads to an increase in antibiotic resistance by genetic selection and other mechanisms. According to a 2019 CDC report, it is estimated that over 2.8 million infections each year are caused by antibiotic-resistant organisms, resulting in nearly 36,000 deaths. That is a lot of deaths, but it pales in comparison to the worldwide estimates attributable to antimicrobial resistance in the future. In 2016, the Review on Antimicrobial Resistance estimated that worldwide, by 2050, the number of deaths attributable to antimicrobial resistance will reach 10 million. Comparatively, when this research was performed in 2016, deaths attributable to antimicrobial resistance were only at 700,000 annually worldwide. The good news is we are still more than a quarter century away from 2050, which means we have time for a course correction. What then can we do to actuate this course correction? There are several things that can be done from a clinical perspective. First, we can follow guidelines and practices set forth by infection prevention and control professionals. This includes screenings and communications upon transferring patients. It is also important to work with lab and local and state health departments to be aware of infection and resistance patterns, along with reporting laboratory data. Last, but definitely not least, is to follow CDC's antibiotic treatment guidelines, along with appropriate diagnostics to guide antibiotic therapies. This is especially important when diagnosing and treating UTIs, as improper or inappropriate antibiotic use in UTIs will lead to increased resistance and is of major concern in the antibiotic stewardship realm. CDC has estimated that 77% of antibiotic prescribing in patients for UTIs was not supported, or in other words, not appropriate for the case. To correct this issue, here are several intervention strategies that we will discuss further. Here we have an intervention flowchart for key moments of antibiotic stewardship with UTIs. You'll notice that there are things that you can do right off the bat when you suspect a UTI, including urine culture stewardship, SBAR, and assessment of Lobb's minimum criteria. There are also steps you should perform later on, also known as an antibiotic timeout. We will discuss each of these further. We'll start with urine culture stewardship and appropriate culture ordering. Too often, asymptomatic bacteriuria is treated with antibiotics, when in reality patients don't actually need the treatment. Listed on the slide are recommended indications for urine culture ordering. Indications include acute dysuria, acute pain in the genital area, fever, leukocytosis, costovertebral angle pain, new incontinence, suprapubic tenderness, or visible hematuria. If there are not signs or symptoms indicative of a UTI, follow urine culture stewardship practices and don't order the culture. Along with appropriately ordering the cultures, urine cultures should be appropriately collected, stored, and processed as well. Preventing the contamination of the urine, along with rapidly transporting to testing, can help ensure that an accurate representation of the urine microbiome is possible. Per the CDC and institutions implementing such techniques, use of urine culture stewardship has more of an effect than just improving antibiotic use. Institutions reported fewer urine cultures being ordered, a decrease in asymptomatic bacteriuria diagnoses and associated costs, a decrease in CODIs, and most importantly, no increase in reported patient adverse events. A second recommended strategy is very similar to the first and is called Lobb's minimum criteria. It was created to reduce the need for empirical decisions in antibiotic prescribing, and criteria exist for many different types of infections, not just UTIs. It differs from urine culture stewardship in that the minimum criteria deal more specifically with antibiotics, rather than just whether to order a urine culture. As we see here, LOB's minimum criteria is a checklist to be completed prior to beginning an antibiotic therapy. If the criteria is not met, then it is not recommended that antibiotics be prescribed to the patient. It also conveniently gives different recommendations for catheterized and non-catheterized patients, as risks and outcomes differ for each group. Another resource that could be used is called SBAR, a communication framework used to facilitate important information including the situation, the background, assessment needs, and a specific request. Its intent is to guide complete communication between the nursing staff and the prescribing clinicians. As an example, we see here that the nursing staff is asked to communicate the patient's situation in terms of the patient's vitals. Nursing staff is then asked specifics about the patient's treatments and active diagnoses, including catheter use, dialysis, and medications as part of the background section. For the assessment part, nurses are asked to include what symptoms of UTI a patient is experiencing, depending on whether a patient has an indwelling urinary catheter. Finally, a request is made to help the patient. This could be in terms of ordering a culture, initiating antibiotics, or encouraging fluid intake. What is most important is that all the pertinent information for a UTI diagnosis is consolidated and communicated to those people who need it, which is the purpose of SBAR. After antibiotic therapy is started, antibiotic timeouts are used to assess the usefulness of the therapy. Generally performed 2 to 3 days after beginning the antibiotic, the reassessment includes culture results and patient well-being. These timeouts are generally focused around 4 questions. The first question assesses whether a patient has an infection that will respond to the antibiotics. Results from appropriately ordered and collected cultures will generally inform this, as they will tell you if the patient actually has a UTI or if their symptoms stem from other issues. If resistance testing is performed, you can also learn whether the organism responsible for the infection is susceptible to the antibiotic regimen being performed. The second question assesses whether the right cultures and diagnostic tests have been performed. Verify that the urine culture has been sent and that the lab was able to process it. If this step has been missed, ensure that the culture gets sent as soon as possible. The next question assesses whether antibiotics can be stopped or if they can be improved. This could mean stopping the regimen if the culture came back clear, or it could mean using a more specific antibiotic now that you know exactly what is growing in the urine. A more targeted approach could not only improve the outcome, but it also helps prevent antibiotic resistance. The last question deals with the timing of the antibiotic. How long should the patient use this antibiotic to make sure that the infection is completely clear, but not so long that it's no longer treating the infection? What education needs to be given to the patient about the length of the antibiotic use if they end up leaving the facility before they finish the antibiotic therapy? Here we have a real-life example from the Royal Victoria Regional Health Centre in Ontario, Canada. A couple of things to note. They perform their reviews at 48 hours, where they check diagnostics, microbiology, and clinical notes. They also do this with an antimicrobial stewardship pharmacist as well, to ensure that the right antibiotics are being used in the right settings. Every facility will have their own way of doing this, according to their resources and existing processes, but this is an excellent model to build off of. The final strategy that we would like to discuss is a sort of summary of everything we have talked about in a more succinct way. It is called the 5Ds model, with the 5Ds being the right diagnosis, the right drug, the right dose, the right duration, and de-escalation. These 5Ds are designed to ask important questions about prescription of antibiotics for patients with UTIs. The first D is right diagnosis. When it comes to UTIs, we need to make sure that we are making and documenting the right diagnosis. This could mean investing time into routine trainings on urine collection and transportation techniques. It also means correctly documenting everything so that patients who don't need antibiotics don't receive them, while those that do need them get them in a timely and appropriate manner. The second D is right drug. Some antibiotics work better with certain organisms, so when culture results are available, antibiotic prescriptions should be aligned with them. Additionally, antibiotic resistance tends to be similar across geographic areas, So local antibiograms can be used to appropriately prescribe an antibiotic to which local organisms will be susceptible to. Local antibiograms can also be created on a facility level by maintaining records of unknown resistances and can contribute to prescribing the right antibiotic as well. The third D is right dose. Different patients have different needs, and different antibiotics respond differently to different patient characteristics. We want the antibiotics we prescribe to patients to work, so we need to make sure that those antibiotics are site appropriate and patient appropriate. This would include taking into account a patient's renal function, as this can affect the effectiveness of the antibiotic. The fourth D is right duration. We don't want patients to take antibiotics for any longer or any shorter than they need to, as both scenarios can be detrimental to the patient and increase antibiotic resistance. Routine audits or timeouts should be performed to ensure the timing of antibiotic use is still appropriate. The final D is de-escalation. It is very similar to the previous D, right duration, but it involves more personnel. It is encouraged that post-prescription, a pharmacist or other antibiotic steward should assess the prescription to ensure its appropriateness. This would involve checking to see if it is the right drug, right dose, and right duration, like an additional checkpoint. Doing so helps the patient and prevents antibiotic resistance from spreading. Now that we've tackled the importance of UTI antibiotic stewardship and some of the techniques that can be used to promote antibiotic stewardship, it's time to ask the question, what now? You can start by making sure you are informed. There are so many aspects to antibiotic stewardship, many more than can be included in a training such as this. Take the time to inform yourself so that you can better help your patients and your facility. Also, don't be afraid to ask questions if something feels off about a procedure or a prescription. It doesn't hurt to ask, but it definitely could hurt to ignore. You can also be an advocate for change. You could start a chain reaction in your facility if you're willing to speak up, especially with your management. Share what you've learned today and what you will learn as you dive deeper into antibiotic stewardship. If you believe something we have discussed today could be implemented in your facility, make sure to communicate it and work with your facility to implement it. Thank you so much for your time. Hopefully you have learned something that can better improve your practices at your facility. Good luck with all of your UTI antibiotic stewardship needs.